Okay, well, good morning, good afternoon, or good evening, wherever you are located, and thank you for joining us today. Welcome to this free webinar to celebrate the World Day of Care and Support. As you can see, I have a little bit of a cold, so I apologize for my voice. I hope you understand me. My name is Liliana de Lima, and I'm the Executive Director of the International Association for Hospice and Palliative Care, IAHPC. We're hosting this webinar today, and just so to let you know that this webinar is being recorded and that it will be available on the IAHPC website for those who wish to revisit the session or are unable to join us live right now. So in addition to introducing the moderator for today, I just want to share a few thoughts on what we call the new normal for IAHPC, which is including the voices of caregivers and patients, and also this whole idea of the caregiving focus. Some of you know that a few months ago, the IAHPC and the International Neuropalliative Care Society hosted a palliative care or neurological condition course. The new aspect of that is that we had a patient or a caregiver in every module, and for us it was a kind of a breaking new ground. We had never done this before, and we valued this experience. We learned so much during that course that we want to make this, the new way to do the webinars. We have been disconnected from the persons that we're supposed to be advocating for. It has been an incredible learning experience for me personally, but also for the IAHPC and the people that we work with. By listening to the voices of patients and the caregivers, I realized that frequently their worries and concerns or needs were not addressed or even considered by the care team. Palliative care is supposed to be very patient-centered, and then this was not always the case, as we saw in that course. Patients and caregivers are often left out from the decision-making process and planning, and this is certainly wrong, which is why this webinar is so important, and why the perspective of the patient and the caregiver should always be taken in consideration into the treatment plan, and then also as part of the communication process. So our promise to all the IAHPC members, to the global palliative care community, and the participants in this webinar is that we will continue to open spaces to have your voices heard. And if you are unable to speak, we will serve as a conduit to help your message get across. So count on us. All right, now it's my pleasure to introduce you to our moderator for today, Dr. Catherine Pettus. She is the IAHPC Senior Advocacy and Partnerships Director, and she has been with the IAHPC for 10 years now, believe it or not. Catherine has been working relentlessly to bring awareness about lack of access to palliative care, and in particular, access to essential medicines. And we are very, very lucky to have Catherine in our team. Catherine, thank you for doing this, and please go ahead and take over.
Thank you, Liliana. I'm very lucky to be here and to have this work. I'm just going to share my screen, so give me a second. Thank you for being here, everybody. So thank you for joining today. And I'm Catherine Pettus, as Liliana said, the Senior Advocacy and Partnerships Director. And please take a photo of the QR code and join us in our global movement for palliative care if you're not already a member. I'm going to tell you a little bit about the IAHPC and why we're here today, and then launch straight into our webinar. So we're a global membership organization founded in 1980 with more than 1,200 members in 149 countries. You can see the members in your countries by clicking on the red dot in the interactive map on our website. The IAHPC's Board of Directors is made up of a very diverse group of palliative care professionals from around the world. We have 4 areas of work, advocacy, education, research, and information dissemination. We advocate within the UN system as a non-state actor with the World Health Organization and as a civil society and organization in consultative status with the UN Economic and Social Council, which means we're invited to participate in meetings of the Commission on Narcotic Drugs, the Open-Ended Working Group on Aging, the Human Rights Council, and the General Assembly, among other UN organs. Oops, sorry. The UN, the unmet need for palliative care is why the caregiving crisis is already with us, but the projections of health-related suffering by researchers show the absolute urgency of addressing this issue now, because 86% of global palliative care need is currently unmet. And that means that caregivers are laboring to care for their suffering loved ones with no assistance or professional help, usually at their own expense and at great cost to their own health, as we will hear from the other panelists. The fastest growing population needing palliative care is older persons and persons in lower income countries. The need is driven by cancer rates and non-communicable diseases, barring, heaven forbid, another pandemic. The research also shows unequivocally that caregivers need education, support, and above all, confidence, because including in the administration and management of medicines, and so they can treat the pain and suffering of their loved ones. So we're really focusing on this need to help caregivers learn and be supported through policies, if in particular, because the UN has woken up to this enormous ethical, social, political, economic, and health issue, and last year declared an International Day of Care and Support with a General Assembly resolution. This is the resolution number, you can look it up, that recognizes that comprehensive care and support policies aimed at reducing, redistributing, and valuing unpaid care and domestic work are conducive to the well-being of society and all its members, in particular children, older persons, persons with disabilities, and the achievement of gender equality and the empowerment of all women and girls, because as we know, more than 70% of all caregivers, paid and unpaid, are women and girls. There's a high-level event going on right now at UN headquarters. It'll be taped on UN TV so we can watch it later to bring attention to this issue. But our webinar today will focus on caregiving specifically in palliative care for people with health-related suffering. And you will hear from panelists from Europe, India, Africa, and Canada about caregivers who had palliative care support, as well as those who did not. We hope to do a series of webinars next year going into much more detail and including other areas of the world where we have members who can share their expertise to support caregivers. This webinar today falls under the advocacy program because we need to advocate for good caregiver policies. We're hoping to build on today's learning so it also contributes to our education, research, and information dissemination pillars. If you agree that we should do more work on this, please join us and complete the survey you'll be asked to complete at the end of the webinar. So to conclude this introductory part, caregivers are both paid and unpaid. They may or may not be paid, they may or may not be professionally accredited, but they're an integral part, as Liliana said, of patients' care teams and are often sidelined in meetings and in policy decisions. This new report on care work by the International Labor Organization can be found on the website of the International Day of Care and Support. So you can just Google that. There's lots of resources on there or on the ILO website. But now I'm just going to talk briefly about the first two speakers who will address this important topic for global palliative care are giving a joint presentation. You can see the links to their bios on our website once it's uploaded onto our website with the recording of the webinar and the resources. Professor Deslions is a sociologist and professor of palliative care research at the Free University, Brussels, and Ghent University in Belgium. Since 2000, he directed the End-of-Life Care Research Project, End-of-Life Care Research Group, of both universities, and last year he was elected as the president of the Public Health Palliative Care International. So Louise Dare is a researcher at the same universities as Dr. Deslions, and she has a background in criminology and international affairs, like I do. Her research focuses on civic engagement in neighborhoods around the topics of serious illness, death, and loss, and her doctorate reported on an in-depth study of two compassionate cities in Flanders, Belgium, specifically examining the development and evaluation of community-based approaches to serious illness, death, and loss. So my friends, Luc and Louise, you have the floor, and I'm going to take myself off so that you can share.
Do you see my slides? Hello.
Yes, you just need to put them in presenter mode, Luc.
Okay. It does not seem to work now.
Yes, you can go to dia-voorstelling, Luc.
No, but I have to share it first.
Yeah, but it is shared. Yeah.
Catherine, did you stop sharing the slides?
I did.
I don't know why it is not working.
If you click on the screen down at the bottom.
That's what I did. I followed the same procedure, and now it does not seem to work. Louise, can you share your slides from the beginning?
Yes, I can. Then you just have to unshare them.
Maybe I can start again because now you see it probably. Now
Yes.
the slides are on. That's my sharing. Okay.
Perfect.
So welcome. It's a pleasure for me to be here in this webinar. So I hope we have a nice discussion at the end of the webinar. I'm going to talk about public health palliative care, and Louise is going to talk about civic engagement in serious illness. We both are from the Free University of Brussels and Ghent University, and we are also both representing the Center of Expertise on Compassionate Communities at these universities. So these are our collaborators, the different people of our team for this research project. But I want to start with a very simple rule, because it's World International Day of Care and Support. And if you ask people, who are your carers? Most of the people will be thinking about their professional carer. So if I ask someone, who will be your most important carer at the end of your life? Many people will say that it's their GP or their oncologist or whatsoever. And what in reality is the case is that everyone is a potential caregiver. And so the 95 5% rule means that less than 5%, even in a hospital, when you're a patient in a hospital, less than 5% of the time that you're in your bed in the hospital or outside of bed, there will be a professional caregiver next to your bed. So who is filling in the 95% rest of the time? Either you will be alone, maybe at night, or you will be with your family, with your friends, with your spouse, with your children, with a neighbor or whatsoever. So what we have been neglecting in palliative care is a very key question, namely, how do we as a society fill in this 95% rule? So this 95% of the time that are the seriously ill, people confronted with loss and dying. So who is going to support these people in this 95% of the time? So this is a key question. And we have been focusing for a very long time on 5% of the time. So there is a growing awareness by more and more people for that there is an urgent need for a kind of paradigm shift in palliative care, from a medical model of palliative care towards a more comprehensive model of palliative care. And we call it the public health model of palliative care. So a basic premises of the whole public health palliative care movement comes from two very good books, but already more than 20 years old, from Alan Kelleher. So he first wrote a book in 1999 on health promoting palliative care, which was actually completely based and inspired by the whole development and promotion of health promotion within the WHO. And the second book was published in 2005, where he explained what compassionate cities could be. Or compassionate villages. And so the premises of this public health palliative care movement is the following statement, namely that death is a social event with a medical component, but it is not a medical event with a social component. And the latter has been the translation of palliative care far too often in the last 20 to 30 years of professionalization of palliative care. And so the social component is as important as the medical component, and even more important if you take into account the time that people are dedicating to serious ill. So the dominant clinical policy pyramid of palliative care is pretty much a clinical policy pyramid, where on the top of the pyramids are the specialized interdisciplinary or interprofessional services for palliative care. And if you're lucky, your GP or family physicians might be trained in palliative care as well, or your oncologist might be trained in palliative care, which we call generalist palliative care. Or we have a good model of integration of palliative care into the regular healthcare system, which we are all already trying to do in oncology, where you have integrated consultation with oncologists and palliative care. But where is the biggest capacity? So we are lacking now already a huge amount of capacity in palliative care. And so in order to increase the capacity for caregiving in palliative care, we need to complement or to supplement the clinical policy pyramid with what is here shown at the basis, with palliative care promotion and community approaches in palliative care. And a very good example are the compassionate communities. Of course, each of these layers in the pyramid are interrelated to each other, but what we need to do is the development of the bottom part, and that will create a large level of capacity for a potential very good palliative care. So this is a study from Australia, from Samaraun, showing that actually for bereavement care, as an example, only 6% of the patients in this study were at high risk and were in need for really medical support, for referral to a mental health professional. But the vast majority can cope with bereavement and loss They have a low risk or moderate risk, and a majority of individuals can deal with that, with the grief, by support of family and friends. And that is very important. Death and dying used to be a very normal part of society in the Western world back 50 years ago. And we lost this connection with society during the last 30 years in the professionalization of palliative care. So the foundations of public health palliative care approaches are based on the Ottawa Charter of Health Promotion, and translated to the end of life, it means we need to facilitate education and information for health, dying, death, and loss to the general public, facilitate also social support for personal and community, both personal and community-based support. We have to develop also personal skills that add value to people's ability to cope and develop alongside their experiences of dying, death, and loss. And we have to encourage the services to reorientate towards health promotion rather than simply confine themselves to clinical service. And we need to combat death-denying health policies and attitudes in the general public, the media, and the health professionals and services. So just as a kind of analogy, so who is for you responsible for your cardiovascular health? Is it your cardiologist who is responsible for your cardiovascular health? I don't think so. Is it your general practitioner or family physicians who is taking care for the primary care, who is perhaps prescribing you statins as a kind of preventive medicine? Yes, a little bit, but it's not as much as your own lifestyle. So who is mainly responsible? It's you, because you develop a very healthy lifestyle. You prevent a sedative lifestyle. You do some sports, but especially you try to eat very healthy. And for trying to eat very healthy, it's not just an individual choice. It is a societal choice. It's a society who delivers healthy food. They regulate the food production. They control the food. There's also sanctions. So there's a whole range of public health measures in order that we can have healthy food on our plate. And in order to do so, it's much more easier when you have a kind of a global health policy within the city or the village or the municipalities that you're living. So actually what we do is that everyone is responsible for our health, not just the health services. And we call that the public health strategy. And the same needs to be done for palliative care. So we need a public health strategy for palliative care. It's not only the specialized palliative care services that we need. It's not only the generalist palliative care that we need to develop. Public health approaches towards serious illness, end of life, caregiving, and loss are equally important as the specialized palliative care services. So we need to develop prevention of suffering, early intervention, harm reduction. For example, we have very, very few laws on palliative care and how to prevent aggressive treatment at the end of life. So we need informal palliative care. That's what it's all about today in the webinar. We need health promotion towards the general public. That needs to be embedded in compassionate neighborhoods, compassionate communities, and it's very facilitating when these compassionate communities are embedded in a compassionate city policy. So also prevention, early detection, harm reduction is important. So why do we need public health palliative care? I said already the 95% rule. Second is that the social determinants of dying and caregiving and grief are far more important than any other element that determines your health or your death. The 80% rule is another very interesting rule, because we know from research that 80% of problems in palliative care are not physical problems. They are mental problems and social problems. Many of our professional services in Belgium are dealing with these social problems, although many of these social problems can be dealt with by volunteers, by family members, and that you do not need to take away the time of specialized palliative care nurses. So health promotion needs to become far more important. Prevention, harm reduction, early intervention, palliative care, in other words, is everyone's business. So everyone's, and it does not need to be the responsibility of the health sector. Palliative care is also the responsibility of other sectors. You can think about education system. So we need compassionate schools. We have developed already quite a lot of interventions to create compassionate schools. They are very successful in Scotland. So we have the know-how, we have the competency, we have the expertise to develop a compassionate school system. So it's the responsibility of the Minister of Education, but it's also the responsibility of the Minister of Social Affairs. Why does the Minister of Social Affairs is not developing, for example, a social statute for compassionate caregiving? It's also the responsibility of our economy. Right now, some of my colleagues are developing a European project on compassionate workplaces. So if we can work in compassionate workplaces, we could prevent a lot of morbidities and mortalities. So I think this is the end of my presentation. This last slide is just showing that it's also an academic activity. We have an international association, which is called Public Health Palliative Care. We have worldwide conferences. The last world conference was last week. We have a professional journal, Palliative Care and Social Practice. We have activities in different universities, and we have even a compassionate university. Thank you very much, and I'd like to give the floor now to Louise, and I will stop sharing my slides, Louise.
Yes. I will quickly share mine. Yes, thank you very much for the introduction, both Catherine and Luc. I'm very happy to be here today. And as Catherine introduced me,
Louise, could you put your slides in presentation mode? There you go, almost.
Yeah.
Okay, now bottom right. No,
Yeah.
you keep going back to so you can see your notes.
Okay.
Down at the bottom right, near where the % sign is, on the other side. On the other side of the slider.
Just, you can still see the notes probably, or
Yeah, so go back to where you were and then go down to the slider on the left-hand side of the slider.
yeah.
Right-hand side of the screen on my side when I'm looking at it, but other side of the slider.
I will quickly stop sharing and try again. Still with the notes, or?
Yeah.
Still with the notes. I think you have to take the third screen from the left. Yeah, this one, I think. Weerga voor presentator.
Yeah, but it's still with the notes.
Try.
Yeah. No, it's okay.
There you go.
I will quickly go to my part. Yes. So as Catherine introduced me, I conducted my PhD research on the development of two neighborhood initiatives, specifically on the topic of serious illness, death, and loss. And the initiatives were located in two cities. One was in a rather rural city, in Herzelen in Belgium, so probably not that known internationally. But the second city was Bruges, and that one is maybe already a bit better known internationally. So that is the context in which I conducted my research. But today I will focus on one of the first steps we did in that research, and that was on conducting a systematic review on civic engagement initiatives around serious illness, death, and loss worldwide. And I will present you the gist of the findings. But if you're interested in reading the whole article, you can scan the QR code here. So the systematic review was actually to look at in what context, why, and for whom are there already civic engagement initiatives around serious illness, death, and loss worldwide? Also, how are they developed and how are they sustained? That was the second research question. And we also wanted to look at how have they been evaluated and what was actually their impact. So we looked at publications in English, and we were specifically interested in civic engagement initiatives around serious illness, caregiving, death, and loss. And this civic engagement we defined as all collective action undertaken to help improve connections between our conditions for people in communities. And we deliberately chose a very wide definition of civic engagement so that it would encompass all sorts of formal but also informal support in communities and also caregiving. We also included some initiatives, and we included those initiatives that we called service-oriented. But actually, with service-oriented, we mean initiatives where communities were involved, but with the sole aim of enhancing the quality of a service and not enhancing a more collective goal of empowering communities. So I'm not going to bore everyone with going very much in the methodology, but just quickly that we started from peer-reviewed publications in 6 databases. And then we searched for additional grey literature on the initiatives that we included. And we initially found very many initiatives, around 1,700. But when we used the inclusion criteria, we ended with 23 studies reporting on 19 civic engagement initiatives worldwide. And what may be interesting is to look at the map of how those civic engagement initiatives are distributed. And actually we found that a lot of the initiatives could be found in countries where English was one of the official languages. And by that I mean that we found initiatives in the US, in Canada, in Australia, but also interestingly, we found an initiative in India, in Kerala more specifically, and we also found a couple of initiatives in Africa, in Mozambique and in Ethiopia, I also think. So when you look at this map, you might think that there's more of an Anglo-Saxon influence, for instance, the influence of Alan Kelleher on compassionate communities. But specifically, when you look into the initiatives that were, for instance, developed in Asia or in Africa, we saw that those initiatives were actually already developed before the term compassionate communities was used. So actually, these were already initiatives, compassionate communities avant la lettre, so to say, showing that, that compassionate communities were actually already there before the concept got into use by Alan Kelleher. Also, when we look at the development of these initiatives, we found a wide plethora of activities ranging very different kinds of support, but often there was a focus on navigation of people who were seriously ill or caregiving to existing resources. And I think that could have to do with the fact that in communities, you already have a lot of resources when it comes to serious illness, caregiving, death, and loss. But it's often a case of navigating people also to what is already there in communities. Also, interestingly, when you looked at the development of these initiatives, we found that many were actually initiated through community academic collaborations. Like, for instance, was also the case in my research, but only 3 out of 19 initiatives were fully community owned, and 4 out of 19 were owned by community organizations such as NGOs or hospices. And this one was actually very important, this result, when we looked at the sustainability and continuation of these initiatives. And what we found was that only 8 initiatives specifically said that they wanted to continue their activities. And it were specifically those initiatives that were either entirely community owned or where the community was involved through a far-reaching engagement, showing that community ownership was actually very important for sustaining and continuing initiatives. 3 initiatives reporting the discontinuation of their activities, and mostly it was the funding that stopped for facilitating these initiatives. So also an important message, I think, to policymakers, that if you want to invest in compassionate communities and community-based initiatives, you should do so in a long-term way. Also, when we look at recommendations for sustainability, the most found recommendation was that those initiatives have a better chance of sustainability when they are included in a broader context of public involvement, and specifically public involvement around serious illness, death, and loss, such as is the case for compassionate cities, where there is a policy framework for including these initiatives. But still, future research should specifically look more into the sustainability of these initiatives. Quickly, something on the evaluation of the initiatives, that most of the initiatives were in fact evaluated, but the quality of evaluation was there was a variety in this quality. And although all the initiatives demonstrated some positive benefits as a result of their civic engagement, there was limited transparency or limited insight in how the evaluation was conducted. And most studies only focused on one particular aspect of the initiative, for instance, a training for community members. So what we found is that there is a blind spot of compassionate communities, primarily in middle and low income countries. We are in need of a thorough evaluation of compassionate communities, and sustainability is a key challenge, so it should also be part of this evaluation. So this was a study we conducted in 2021, and I was very happy to receive the chance of doing a review again in 2024 with my colleague Libby Salnow. And for this review, we specifically looked in contemporary tensions and challenges for compassionate communities. And we conducted a review of some reviews that were already published on compassionate communities. You can see my own review and also the review of my colleague Bert Quintins, but also recent reviews on compassionate communities interventions, and a Canadian study by Dumont were also included in our small review. And we identified some challenges by looking into this review. We found that compassionate communities, there is a challenge as to, is the community a target or a leader of these interventions? Sometimes we found reviews, which for instance focused on educational activities, but were very much, where the community was very much targeted as having to increase their capacities and skills around the topics of serious illness, death, and loss. But those capacities and skills were provided through training, but the community was not in fact empowered of taking their own actions regarding serious illness, death and loss. So that was an important tension that we found. Also the level on which compassionate communities focused. So when we look at the outcomes of these compassionate communities, very many were focused on the individual level of increasing quality of life, of increasing some accessibility to initiatives, but we felt there was a lack of looking into what compassionate communities can actually do for us on a collective level as well. Then I think the most important tension that we found, and this came also out of the first review, that our view of compassionate communities is very limited. We often find in published peer-reviewed literature, compassionate communities in more high-income countries, in Western countries, but compassionate communities in other continents are often overlooked. And I think that this very much has to do with many of our initiatives involving researchers who can do an evaluation study, but not all compassionate communities, especially those that are very grassroots, have the funding for a researcher who can do an evaluation study and publish it in a peer-reviewed journal. And then there's also the peer-reviewed journals themselves, who are mainly publishing articles in English, and this may also be a barrier for other compassionate communities in non-English context to be published about. Also, the power dynamics in communities. Often there was an interaction between local governments, local organizations and networks, and the communities themselves, but often there was not that much of a reflection how power was distributed to communities, and often power stayed at the level of local governments and also at the level of organizations. So to conclude, although many of these reviews and initiatives that I found want us to have a more rigorous research on compassionate communities, I do think that in applying this more rigorous research, we must include and integrate really a broader diversity of people, approaches, activities and epistemologies, complementing the traditional compassionate communities that we already find in the literature. So these were some of the results we found. And if you have any questions about this research, you can always contact me or Luc.
Thank you very much, Louise. I think we need weeks to discuss these two very rich presentations, and we still have 3 more. So thank you, that's very interesting. I'd like to remind people to please put their questions in the Q&A, and we'll answer them if we have time at the end. We will also answer them on email if we don't have time, and we may stay over if people are willing. But I want to introduce our next speaker from India, who is Dr. Annika Paul, who holds a master's and a PhD degree in social work from the Tata Institute of Social Sciences in Mumbai, India. She has more than a decade of experience in public health with the Tata Trusts, among the oldest philanthropic institutions in India, and currently freelances as an external evaluator for various funding organizations. Annika served as a trustee of Golden Butterflies Children's Palliative Care Foundation in Chennai for 6 years and is a mentor for the International Fellowship in Palliative Care. She has a keen interest in research, particularly in palliative care, ever since a family experience. So Annika, the floor is yours.
Thank you, Catherine, for the introduction, and thank you to IAHPC for this opportunity to speak today. I hope my slides are visible. Today, I'd like to present the experiences and opinions of family caregivers who have availed home-based palliative care services through NGOs in India. This is the flow of my presentation. A little more about the personal bit. I was introduced to palliative care through work when I was working with the Tata Trusts. But palliative care came home when my grandmother suffered from two cerebrovascular accidents, the second of which left her bedridden. And our experiences as a family of caring for her led to the topic for my PhD, where I wanted to understand the experiences of similar families who had experienced home-based palliative care through three of the oldest NGOs in the country. Around the same time, a more newer NGO in Mumbai requested a commissioned research along the same topic. And therefore, what I will be presenting today is a sort of a mix of both studies. So this is data from two qualitative studies carried out across 4 Indian cities, Delhi, Mumbai, Bangalore, and Kozhikode in Kerala. All the NGOs involved offer free home-based palliative care services, and 2 of them also have inpatient hospice facilities available. All the caregivers whom I spoke to had cared for adult patients. They represented a variety of relationships. And at the time of interview or focus group discussion, they had been bereaved for at least 2 months. There were 19 in-depth interviews and 3 focus group discussions involving a total of 23 participants. So some very broad observations, as mentioned by Catherine earlier. There was a distinct feminization. So a lot of females, majority of the primary caregivers were females, and they were also caring for more than one generation of dependents at the same time. The primary caregiver at home, the person accompanying the patient to the hospital, and the decision maker who also the financier could actually be 3 different individuals. Families tried all possible curative options, but once they had been enrolled for palliative care, they had wished that they had received this referral earlier. They came to know about palliative care through a variety of means, but their choice of opting for home care was either because of some personal determination to care for the patient at home, and also dependent on the resources at their disposal. However, everybody prioritized caregiving of that patient above all else. While active caregiving was going on, all domains of the caregiver's life were impacted. On the physical front, they were caring for the patient physically. They were adjusting their household and work routines and schedules around the needs of the patient. But this left them unable to attend to their own aches, pains, injuries. On the psychological front, they had the agony of witnessing their patient deteriorating both physically as well as in terms of behavior and change in personality. And all the while, they had to be hiding their own anxieties and worries from for fear of worrying the patient further. They were completely unable to sleep at night because they were afraid of any emergency happening at any time. Socially, they could not leave the patient unattended, so they were unable to attend any social functions unless they could arrange for an alternative caregiver. And even families and relatives, support from family, extended relatives and friends ranged from zero and ostracism completely to, as Louise referred to, one family experienced the positive benefits of compassionate communities, and their society put together about 200,000 Indian rupees for the cost of treatment and later the funeral of the patient. In spiritual terms, what kept the caregiver going sometimes was the concept of punya, or earning merit by doing good deeds. Yet when at certain junctures when they were truly helpless, they might even pray in their mind that God should just take the patient away. I must mention the financial issues because in India, majority of healthcare expenditure is paid for out of pocket. At least one family had to directly opt for palliative care without even attempting curative care because they could not afford it. And there are other hidden expenses when it comes to even palliative care. For instance, a family might receive an air mattress free by some donation, but they needed to purchase an inverter to keep it filled because they live in a region where there are several or frequent power cuts. When it came to nearing death, the caregivers were usually perplexed by the rapidly changing symptoms that they were observing in the patient. When the home care team visited, if by chance they visited closer towards the end or on the morning of the demise or the day prior, they would drop gentle hints to the caregivers. They would try to be constantly monitoring the patient's condition over the phone as well. At the time of actively dying, there were certain religious or rituals like reciting holy scriptures in the hearing of the dying person or feeding them with some holy water. Funerals were typically organized as per the family's religious beliefs and followed by a certain period of mourning. Caregivers expressed that their immediate feelings were a sense of shock, a sense of relief even, and even a sense of emptiness because they were a little jarred that they didn't know what to do subsequently. But gradually more practical issues took concern, so they needed to have death certificates issued. And again, that procedure varies state by state in India. A few weeks later into bereavement, they now had time to attend to their own injuries, but their sleep schedules had definitely been damaged. They thought back a lot and wondered whether they had been able to provide the best care to their patient. There were a couple of caregivers where it felt like they might have extreme depression, but they did not perceive the need to consult a professional. Certain communities had a period of seclusion for the widows, but by and large, caregivers are very happy to share their skills gained as caregivers as well as donate any material to help any other patient and family whom they knew of in the neighborhood. There were certain rituals that continued as well as fulfilling the deceased patient's last wishes, making donations in their names, so on. From the perspective of the NGO, they did prioritize caregivers whom they perceived at risk for follow-up phone calls. And some NGOs also have the practice of organizing annual memorials where all bereaved caregivers are free to attend and reflect upon the patient whom they have lost. So what the caregivers required was home care and inpatient hospice to be provided on a sort of continuum. where they could receive advice from the home care teams and manage as far as they could manage, but have hospice for backup if even for a short period if required. They had a lot of training and information needs, but each of this needed to be customized to the family's requirements. They needed access to home care, or at least advice 24/7, because current practice is that home care teams, which are fewer in number, are sent out to a certain specific area on a certain day, and they work around 9 to 5 working hours. So out of hours care and an emergency in a different area could not easily be catered to. Families also wanted a lot of public awareness because they confronted a lot of myths about cancer as well as morphine. So they wanted that addressed. So my gratitude to every single one of the respondents and family caregivers who shared their stories at a very painful time, to the management and staff of the 4 NGOs. The Institute of Palliative Medicine, Karunashray, Can Support, and the Jimmy S. Moria Foundation. My thanks to my faculty and other PhD scholars at my university, TIS. And I will leave you with this quote by one of the caregivers who said, "Tomorrow it could happen to us. So provide care as much as you can from the heart." Thank you for your patient listening.
Thank you, Anika, and for that beautiful ending, which was very touching. I remember when I first read your paper, I was just so struck by one of the findings, which is so obvious, which is that the caregivers said they wish they'd known about palliative care earlier. It's just, that is our work in the front end, is to do that. And then your recommendations for the second part about what each of them needs are very helpful. So thank you. And our next speaker is from Africa, from Uganda more specifically, Dr. Eve Namasango, who's a friend and colleague from the African Palliative Care Association, heads the Programs, Research, and Development portfolio at APCA, and is a Build Care Fellow at Cicely Saunders Institute, King's College London. Eve also coordinates the 300-member African Palliative Care Research Network and is a board member at the Institute of Hospice and Palliative Care in Africa, where she also teaches research methodology. She is the patient engagement and involvement lead at APCA. And Eve, you have the floor. Thank you.
Thank you very much, Catherine, for the very kind introduction. And I thank IAHPC for giving us an opportunity to celebrate the informal caregivers, our heroes in Africa. So Africa is home to over 1 billion people. And in terms of disease epidemiology, the continent has a high burden of HIV/AIDS and cancer, and these make a huge contribution to the need for palliative care. And notably, the World Health Organization projects a shortfall of 18 million health workers by 2030. And what does that mean for resource-limited settings? It means that the burden of care is going to fall more on the already constrained informal caregivers. And this is a piece of my expressive art that when a person is struck by an incurable diagnosis, we sound the African drum to call for help, and communities usually come together. It starts with the family, which takes on the role of caring, and at times the community comes in to support. But if the person is ill for so long, the community will eventually start detaching, and the largest chunk of the burden falls on the informal caregivers, who are usually family members or friends. And the role of informal caregivers, this is informed by evidence from some of our upcoming researchers in the region. Their roles include counseling, administering medication, supporting logistics around hospital appointments, daily household chores, providing social support and companionship, and then nutrition support, economic support, and they support the patients during their anticipatory grief phase. And the community can come in, like I said, but we can already appreciate what the informal caregivers have to do. And who actually is doing the caregiving? It's majorly the young women. Our daughters are dropping out of school to provide informal care, the wives and then siblings of the patients. This is female siblings. And of recent, I'm delighted to say that the men are coming on board and are more involved in informal caregiving. And with that, the African Palliative Care Association has a manual on supporting male caregivers to join the fraternity and provide informal caregiving. And it's high time we updated this manual to address the gender dynamics involved in informal caregiving. And my colleague, Edwina Loko, undertook a study on informal caregiving in Ghana, and she noted that fewer informal caregivers were performing the instrumental support tasks of speaking to medical staff on behalf of the patients. And I think this is a role that needs to be highlighted, and our informal caregivers need to be trained and empowered to support their patients and loved ones better. So yes, so far so good, our giants, the informal caregivers who are doing an amazing job. But what is the toll on them? This is a PhD student I'm working with, and our review has highlighted major mental health challenges, depressive symptoms, burnout, abuse, disability, and catastrophic out-of-pocket costs. And if we don't take care of this resource of informal caregivers, I think the burden in the end is going to fall on our governments, and I don't know how our health systems are going to survive. And after suffering all this, and your loved one passes on, it's as if the burden of caring and then what you go through as a carer. And at the end of the day, we spoke to several bereaved caregivers, and we discussed the impact of the whole experience and then the grief and loss on them. And this group told us lots of interesting things: mental confusion, suicide, and some get frustrated. And if it is a spouse who died of HIV, they may end up intentionally spreading HIV because of the stress, because of the mental distress, the loss of hope, the loss of interest in life. So compounded mental health distress and stress should not be ignored among our informal carers. So how can we support the informal caregivers? They need support with healthy coping interventions, respite care so that they can take a break, education and training so that they know what they are doing and they struggle less. And dear colleagues, let us appreciate them and value them. And countries like Botswana in Africa are coming up with more interesting best practices. Botswana is one of the countries that is giving financial reimbursements for informal caregivers and home-based care kits for all patients who are receiving home care. And this support extends also to the informal caregivers. And I feel this is what it means to live universal health care coverage. And we call upon other governments in Africa to take this on and support our patients and their informal carers. And lastly, I want to call to your attention the upcoming 8th International Conference on Palliative Care and Allied Health Services, which is going to be held in Botswana in 2025. I acknowledge several people, the informal caregivers who took part in our engagement and advisory group discussions, and then Edwina Opare, Ephraim Chisangala, and Chitovu Mobile. Thank you very much, and back to you, Catherine.
Thank you, Eve, for that very touching presentation. It would just really touched me that you said our daughters are dropping out of school. Terrible. But good news about Botswana. I didn't know that they were doing this very good initiative with home-based care kits and subsidies for caregivers. That's really good to know. So we can use that for advocacy. Thank you. And I have questions for everybody, but I'm going to introduce our next panelist, our last panelist, before we have some time, I hope, for questions. Please stick around. Laurel Gillespie is the Chief Executive Officer of the Canadian Hospice Palliative Care Association, CHPCA, and a pivotal figure in palliative care. Her journey into this field was inspired by her own health challenges, driving her to enhance supports for those living with life-limiting illnesses. Since assuming leadership in 2021, Laurel has championed initiatives to raise awareness, advocate for policy reforms, and promote best practices nationwide. And now she's going to help us do that worldwide. So thank you, Laurel. And
thank you so much, Catherine, for the warm welcome. I'm exceptionally excited to share my presentation. And in the spirit of time today, I will try to be as quick as I can. Oh dear, now I'm having the same. Oh, there we go. Can you see the correct slides? You can just give me a thumbs up.
Yep, you're good.
Thank you. So I really, I kind of fell into the role of working in palliative care by lived experience. And I wanted to talk today about, how I believe that there's a moral imperative of all of us who live on this planet to take care of one another, and that it can't always be the responsibility of the healthcare providers or the government, but one another. We have an obligation in that respect. So in the spirit of caring and tending to things, I wanted to acknowledge in the colonial name of Ottawa, where I am located today, that I am situated on the traditional unceded and unsurrendered territory of the Anishinaabe Algonquin peoples that have inhabited and cared for these lands since time immemorial. So I wanted to take this moment to express my gratitude and respect to them and to the land for all that it has provided and will continue for us. So a little bit about the organization that I represent. We're the National Voice for Hospice Palliative Care in Canada, and we work in partnership with our 10 provincial associations that do actually deliver the care on the ground. And I work nationally and internationally with Worldwide Hospice Palliative Care Alliance and different levels of government throughout Canada. Our work includes advocacy for equitable access to quality hospice palliative care, public policy, of course, public education and awareness, and knowledge translation through researchers that we partner with. So caregiving and care of yourself, mutually exclusive? I wanted to talk about life as a caregiver. So as Catherine mentioned, my own journey into caregiving really came to a halt or a critical time for me when I was raising one of my 3 children, has a disability. So I was raising a family. I was a military wife at the time. I didn't have that natural support around me as a family. And My mother-in-law lived with us, who had Alzheimer's and was a wanderer. And I myself, because I was so busy trying to take care of my twins and then a younger child, that I myself became very, very sick with cancer, triple negative breast cancer. And although that was 18 years ago, I was 38 at the time, and not having those natural supports in place really opened my eyes to what the role of caregiving looked like and how I needed to now have care at such a young age. So I think that we often don't think about the long-term consequences of inadequate support. And as we've heard throughout these wonderful presentations and the research that's happening, is it's often falling on the shoulders of women and our daughters, but particularly those women that are in my age group that are either, raising children and trying to take care of parents or extended family, and trying to have a career or a job. And when we're in our prime earning years, which can have a big impact on our own future and our own retirement later on. So how can we improve the situation for caregivers today? There's a couple of different things that we've been working on at CHPCA. One of them is called Advanced Care Planning Canada. And through my experiences as a veteran caregiver, because I've taken care of 3 seniors now and my child with a disability, is that I've cared for people who have an advanced care plan in place and ones who don't. And I can tell you that as a person who was sick, one of the biggest worries that I had wasn't about dying or suffering. It was about being a burden on those that I love and who loved me. And being a burden was not what I wanted. So advanced care planning provides you the opportunity, and I think the responsibility, to clearly articulate what it is that's important to you when you do need care. To what extent would you like to have curative treatments or treatments that could extend your life? To what end? Just what is important to you, so that you can designate and have a supported decision maker who can articulate what those needs and beliefs and values are, should you be faced with a circumstance where you're not able to communicate that for yourself. Another project that we're working on at CHPCA, and in the spirit of compassionate communities, is I believe that as a working person, that it's not always the responsibility of our government to step into place. So we developed at CHPCA a program called Canadian Compassionate Companies, where I believe that to support people who are finding themselves in the role of a caregiver, that it's becoming more and more important to support those employees who have caregiving responsibilities. And I wanted to show you just a few statistics of what it looks like for aging in Canada. So individuals 65 and older, that's expected to grow 68% over the next 20 years. And those aged 75 and older are anticipated to double in the same time period. So by 2046, which seems like it's a long way off, but it's really not that far, the number could triple to 2.5 million people over the age of 85. Disability in Canada is also on the increase. And sometimes people, when they age into their senior years, will also find that they're having concurring disabilities. And nearly half, 42% of seniors with a disability had 4 or more co-occurring disabilities. So that's also a bit of a problem that we're going to be challenged with in the future. So as mentioned before, unpaid caregivers in Canada anyway, it looks like this. 1 in 4 people identify as a caregiver today, and 1 in 2 of us will become a caregiver at some point in our life. So we provide in Canada the equivalent support of 2.8 million full-time paid care providers each year, and 69% of caregivers report deterioration of mental health. So I'm just going to come back again to that role of advanced care planning. So it's a lifelong process about thinking and communicating about the kind of health or personal care someone would want if at some point in your life you weren't able to express yourself. We have a brand new suite of resources available at our website, advancedcareplanning.ca. The new My Advanced Care Planning Guide is available in 10 languages. There's a toggle button. They are based on the top 10 languages that are used here in Canada. These resources are free. You can download it. You can, it's coming in January that you'll be able to do your plan online and store it there and revisit it. But I wanted to just mention that it is a life, it's a life planning model, right? Like we plan for our state, we plan for, you know, going to school. We plan for all of these things, but we don't often reflect and take the time to talk to someone who's close to us about what we would want for our future medical health care needs. So some supported decision-making principles. People want to assume that, you know, people want to have other people understand and assume that they can still make decisions for themselves based on their needs. You need to understand the individual and their preferences. Are the right people involved? Some people don't have any family to rely on. It might be a neighbor, it might be a friend. That you can change your mind in an advanced care plan, and you can go back and forth and change as we go through some of life's different stages. As an example of getting a divorce or you know, getting married or buying a home, things change. So it's always an opportunity to change your advanced care plan. Look at what your options are and making sure that you communicate that regularly. So again, I mentioned the Canadian Compassionate Companies. That's where we're trying to encourage companies to be more progressive with their human resources policies to support those who may find themselves in a situation of needing to provide care. So by that, we want to see companies having flexible work arrangements so that someone, if they need to be at home with their loved one, can do so. But there is a vetting process, and more information is available on our website. And there are a number of other countries that have reached out to find out how we started that. So some of the policy work that we're currently working on is a national caregiving strategy. We've been leading the palliative care hospice panel for a mental health summit here in Canada. And our aim for public policy is to make sure that palliative care is universally available to anyone in Canada, and hopefully one day we won't need to be having these discussions. So some of our research partners, there's some great programs that are happening about care, inclusive and accommodating organization standards. And then there's NavCare research that's helping pair people up with a volunteer to help navigate the healthcare system. I do have references here on my slides available. And I just wanted to sincerely thank the panel. I'm very humbled to have been included, and a huge thank you for all of the work that you continue to do at the International Association for Hospice Palliative Care. Thank you so much.
Thank you, Laurel. Thank you very much, and for sharing your personal experience, which we'd like to hear more about. If we have time, that would be great. And just staggering statistics about aging in Canada, but it's all over the world, and what's going to be extraordinary caregiver burden. Before we get to the questions, I just want to say a brief thing about, because that we have quite a few participants from Latin America, is that we didn't exclude you deliberately. Of course, it's just a question of time. And I'm really hoping that we can have another panel next year and another discussion with the compassionate communities in Latin America. I'm fortunate enough to live in Spain, and I know that there's Silvia Labrada from the Contigo Compassionate Communities Office is here, and she's got a lot to say about the compassionate communities that are growing all over Latin America as well. So I just wanted to give a shout out to that because there's just so much good things going on in the world at the moment. So I'm going to get to some of the questions. If people could please put their cameras on, because I'm not sure who is going to be taking the questions, But one of the first questions we got was from someone who's decided to remain anonymous, who says in the, I think, lower and middle income countries, the large load of caregiving is done by family caregivers, women, as we keep saying, although, Eve, I love it that you're including men. However, community-based palliative care teams, though they visit occasionally, do not consider patients and caregivers as partners in the care decisions and how to improve that. So who would like to, I mean, this is one of the questions that we had asked right in the beginning is we notice, and I, as a caregiver for both my sisters, saw that as a caregiver, I was not asked to be part of any kind of interdisciplinary team decision-making and was sidelined. And I had to sort of use some sharp elbows to get myself into the discussions. But is there anyone who would like to answer that question about how people can be more included in the teams? Luke, did you put your hand up? What do you think?
I'm happy to start the discussion. I think it's a very good question. It is a very complex question also. And there is some evidence about how to get more integration of informal carers and professional caregivers. And I think we have, as usual, we have to work at both sides. So we have to work at the side of the professional caregivers. They should realize that the informal caregivers, as I have said, 95% of the time are taking care for the seriously ill people. But I think we can also train volunteers and informal caregivers. There's some initial trainings being developed in Belgium. We have a large network of volunteers for chronically ill people. And we are developing now a training modules for the sign posting role of volunteers. As informal carers are with the patients and with the family, they know the context in which a serious ill is taken care for much better than most of the professional caregivers, no doubt. So that is very important. And so that knowledge needs also to be part of the decision-making process of the doctors or the nurses or physiotherapists. So that is one thing. I think doctors and nurses should realize that caregiving is much more than what they are doing.
Yeah.
And that has to start at medical school, that has to start at nursing school, that has to start at social work schools, that has to start as physiotherapy schools, etc., etc. So when it comes to, there's more and more training on interprofessional caregiving, and that's good. And still they do not know how to handle that. But I think they should immediately start to bring in patients, to bring in caregivers in these modules at medical school. So right now in Belgium, we are just the last 5 years at medical school only starting to have multi-professional trainings, meaning that you bring the students in the medical schools together with the nurses, the physiotherapists, and they have workshops on cases that they jointly discuss. So you need to know each other in order to care for each one, for each other. So that is very important. We all, especially the professionals, they speak their own language. And
Yeah.
said they often do not even understand each other, the professionals.
Yeah.
So they need to take that into account, that the informal carers are a full component of the caregiving system. And so there's a lot of work to be done in palliative care in order to make that happen.
Thank you, Luke. Does anyone else?
Can I add something?
Good, Eve, please. Yes, thank you. Just
Yes,
jump in.
yes, I've been a caregiver, definitely 3 times. And I want to make reference to an emerging model, which I really appreciated, and it's at the Uganda Cancer Institute. The healthcare professionals did invite us in as family. And we sat together in a room and we exchanged ideas on how best we can care for my sister. And then we exchanged views on what decisions need to be made and what the goals of care are. And generally we were in agreement, and it really improved our end of life experience as a family and our grief and bereavement outcomes, because to us as a family, we felt my sister had won the battle against cancer because she transitioned pain-free, and whatever she wanted to do at the end of life, she had an opportunity to do it, and she preferred to die in a hospital. They didn't discharge her by force. And this is a tertiary care facility which is busy, but they've taken the courage to do it just by providing a small side room on the ward and having somebody to book in the families and to give us phone calls to remind us and also to sit with us and prepare us for the news that is going to be broken by the oncology team. I think that is a good model. And yes, we can be person-centered, even amidst resource-limited settings. Thank you.
That's brilliant, Eve. Thank you for sharing that. Annika, you wanted to say something. Anika, sorry.
Thanks, Catherine. I'd just like to also share a bit from our situation here in India. So in most of the situations where the caregivers I spoke to, they had accessed general health care from either another private or public health service provider. And quite often, not even the basic breaking of bad news or informing them about the prognosis in a sensitive manner was done. If at all, they came to know by reading the signpost of the ward that it was a cancer ward that they were going to, or somebody very rudely, maybe not rudely, but very brusquely told them about it. So I think there's a lot of scope for sensitizing all healthcare professionals all across the country about how to break bad news. So that element of health communication needs to be included in medical and nursing curriculum, and it's gradually getting there with the newer batches. That said, I think the question also had to do with the people who are representing palliative care workers on the ground when they are directly dealing with patients. So in India, this is generally a second group of people, not the treating hospital or oncology, where the patient originally was getting curative treatment from. It's another group of people, possibly from an NGO, who are visiting the patient at their home. So these set of healthcare professionals usually have training in palliative care and are generally more sensitive to the in terms of responding to the needs of patients and families. But again, I think it's helpful to have a lot of refreshers and debrief sessions for each palliative care team themselves, so they don't lose sight of some of these important elements of the necessity to involve the family caregivers more. And also, like I kind of pointed out and alluded to, the person who is taking care of the patient at home is usually the woman, and that's not the person who is making the financial decisions. And it's not usually the person who is even accompanying to the patient to the hospital. So the person who sees the medical professional is not the person who is providing care at home. So when the palliative care NGO team goes in, they need to be addressing both groups or both individuals within the same family.
Yeah, that's a complex problem. Thank you. We've got a couple more questions if people are willing to stay for a few more minutes. John Way asked, how can we
Catherine?
Yeah, go ahead, Liliana.
Yeah, just one thought that I had thinking about this question and the comments from the participants. one of the things that came to mind was when we were having the palliative care and neurological conditions course, we had, and one of the panelists was the wife of a patient who had a brain tumor. And he was in the process, in the ICU for many, many weeks. And the progression of the condition is very unpredictable. And in many cases, you can go from being hopeful to things are not so good. I think one of the definite issues that have to be addressed, and Luke talked a little bit about this, is how to communicate well with the family and the caregivers, because sometimes we don't know what to expect. Hope is always needed, but one of the things that she said, I wish they had been more honest with me. I wish that the team and the professionals who were who were there, the neurologists and everybody who was there would have been more honest and saying, there's things we don't know. Because they were always trying to come up with answers, but not necessarily things happen that way. And, we felt that we were misled or things that were kept in secret. And one of the things that the panelists acknowledged was, yes, sometimes we're afraid to even expose our own doubts about the situation of a patient. So I think that kind of honesty and transparency is also needed, and that should be part of the training.
Yeah, absolutely. Thank you for reminding us of that. That was a great series, which our members can watch that whole series on neurological palliative care and listen to the caregivers. So we're at time, but our panelists have said they're willing to stay over a bit if people want to stay on to answer the next couple of questions. How can we sustain a community-based palliative care, especially in lower and middle income countries like Bangladesh? We have a few community-based palliative care services, but it becomes challenging to shift community lead. I'm not quite sure what that means. Anyone want to have a try at that one in Bangladesh?
I think I can try because I know where that question is coming from.
Okay.
I think the question being posed is that how can we, if an independent body or an NGO begins or initiates a service, how can that continuity be maintained or passed on to the general community when, how do we instill that sense of ownership? I think Louise and her study had found that quite a few initiatives which were externally initiated actually had to wind down, and because there was no bottoms-up community ownership of the whole thing, or some external funding ran out. So I think that's a challenge when if the the general community or the look at the people living in that particular vicinity have not been included in a lot of dialogue when at the time of establishing. So perhaps if that dialogue had happened at the initial stages, then some more community ownership could have been generated, and maybe they would be able to dig in and find some resources to at least partially keep the services going, even if external funding withdraws. But I'll let Louise share from her study further.
Go for it.
No, thank you for responding, because I can only talk about my research in Belgium, which is a bit of a different context, but I think the same challenges as to how to sustain initiatives. And what you said about involving communities already from the start of the project and giving them ownership from the beginning is very important, I think. And it also has to do with which people you involve in those processes, because I saw in the context of our neighborhoods, the cities often work together with partners and people they already knew, but there are a lot of other community members and local partners who are very important to the process as well, For instance, I interviewed hairdressers, and they had a lot of experience with serious illness, death, and loss, because a lot of their customers talked about these topics. The same for people who worked in local shops. And also in Belgium, an important partner was also the neighborhood police, actually, the local police. Because when people move in Belgium, the first contact they have is with a local police officer who comes to their house and has a sort of informal talk, and then checks up about the correct address and that sort of stuff. But they actually have a very good view on who the people are that live there and if they are in need of healthcare, of palliative care. So I think it's involving these partners that could be very beneficial to the project, and not only those partners that that you already know or that you typically think of. Yeah.
That's very interesting. Anyone else before we move on to the next question? Luke?
Just add to that point about people whom we don't think of. So here in India as well, we have the local taxi drivers and the auto rickshaw unions, sensitizing them about issues of patients who have palliative care needs, or even geriatric persons is very useful. So it's not something, they're not groups whom we normally think about, but I think we need to broaden our viewpoint as well.
That's brilliant. And in Uganda, then it would be the bodas, right, Eve?
Yes. The borders.
The bodas were great during COVID, didn't they? Deliver a lot of medicines. Yeah. Okay, Luke, yeah. And then Laurel.
Yes, I think when we speak about palliative care, we mean very different aspects, very different contents of palliative care. So one way to address the community is actually to make clear what aspects of human life can be part of palliative care. So helping people to buy groceries when you're seriously ill and you don't have an informal carer is a very important part of palliative care. Cooking a meal for someone is a very important part of palliative care. Bringing a patient to the doctor or to the hospital, helping them to the transport is part of palliative care. So I think community should, and that's part of health promoting palliative care. So many people do not understand what palliative care is. Even doctors do not understand what palliative care is. So they reduce it to symptom control. So if you do symptom control, you think you're the best palliative care doctor, but that's not the case. Of course, we need symptom control, but the most, as I said in my presentation, 80% of the challenges for patients are social challenges for patients, are mental challenges. So the neighborhoods, the neighbors, literally the neighbors, the family, they can all help, but people don't understand. They don't understand that they can help. So we need a lot of health promoting palliative care towards the general public. And it should start in kindergarten. I'm not kidding. It should start in kindergarten. And then you develop and as we have this analogy with health, which I've shown in my presentation. So if I compare myself with my parents and with my kids, there's a huge shift in responsibility and hence also in the overall societal culture of who is responsible for health. My parents, who have died for many years, more than 10 years now, they didn't feel responsible for that. That was the post-Second World War generations. They were smoking like hell. They were eating very unhealthy. The mean weight in Belgium was much higher in that generation than it is today. They didn't yet do any sports or what. So the whole lifestyle was a very unhealthy lifestyle. And if they were sick, I was sent to the doctor. If I was sick as a kid, I was sent to the doctor, and the doctor would care. So my generation took already some responsibility. So we drank less, we smoked less. But if I looked at my children now, and they know that I was drinking, which is allowed by law, 1 glass of beer, and I'm driving my car, they kill me. They just kill me. So that just to show how much power cultural switch has in a society. So having said that, we can reach out for the same objectives in palliative care when we put it onto a societal level. And then we can learn a lot from Africa, from India, but because I know in Kerala, in India, there's fantastic community care in palliative care. So they don't call it compassionate communities maybe, but they are actually in the fact acting as compassionate communities. So it's all about, do people understand that very simple supportive acts are also palliative care? And so people run away from it because it's associated with terminal care. So as soon as the word palliative care is dropped in a hospital, even a doctor don't bring in palliative care early enough. We know, we did a review on what's the length of palliative care in retrospect. And a worldwide review have shown that for cancer patients, it's only the median time is like 15 days prior to death. That's the reality. So we are speaking about early palliative care in professional groups of people, but the reality of our society is that we are only doing terminal care. And that's why the people in general are also anxious about palliative care, because it's completely associated with death and dying. And so I think so there's a lot to be gained by health promoting palliative care in very different circumstances, but also in prevention. Because I give always the example to the students. So why don't we have a law on an obligation for each kind of doctor or for an oncologist, as soon as they start experimental treatment with the doctor, they should be obliged by law to initiate professional palliative care, meaning specialized palliative care. So they have to invite the palliative care service. So this kind of systems which we all use for health, when we drive our car, we put on our seatbelt, we can't drive too speedy or we get a ticket. So all these public health arrangements and systems, we don't have that in place for palliative care. So there's a huge amount of issues that we can put in place, but we need a lot of creativity and implementation of these issues. So also laws, I think I'm very much, and I know that doctors hate laws, but nobody, I said it in a conference on oncology. So why don't you have a law for this when you start an experimental treatment? They should have the right for palliative care in each hospital.
Thank you. Thank you, Luke. That's absolutely true. We've got an advocacy agenda that we'll have to just keep working on. Laurel.
Thank you so much, Professor Delian, for that. It's like you were in my head. Just to kind of add on to that, many years ago, so my background is not obviously in healthcare, I have a business background, but many years ago in Canada, when one of our provinces, British Columbia, was introducing the recycling program, Reduce, Reuse, Recycle program, it was targeted towards 8-year-olds in sort of our grade 2 level, but 8-year-old children, so that they were introduced when they were all given a little miniature blue box to reduce and reuse and recycle garbage or waste. And they brought their little blue bins home, and guess what they talked about at the dinner table was the family becoming engaged in recycling. Anyhow, that was, oh my goodness, in the early 90s. But you're absolutely right, is in order to have this kind of longer term societal or systemic change that we need when it comes to palliative care, we have to get over the fact that, and have a plan that palliative care has a public relations problem. people don't understand what a palliative approach is at the onset of a serious illness or a life-limiting diagnosis. That is the moment in time at which it should snap into place, not during that last 3 weeks. So how do we do that? And one of those things is through, and I mention it again, the advanced care planning piece is getting people comfortable about talking about what their future healthcare looks like and not relying on the systems, the formal systems. Hospitals are where you go to get better. They fix you, but they can only do so much. It's not where we should be going to die necessarily. The other thing I wanted to mention was that advanced care planning piece. I wrote a marketing paper back in 2016 and people thought I was a bit crazy for having this idea. I said, in Canada, like we have 13 different jurisdictional, our provinces all have autonomy over how healthcare is delivered. So it varies from coast to coast to coast and through each province. But one thing is we have our driver's licenses and our health cards. Our universally publicly funded healthcare is delivered through the provinces. So if you live in Ontario, where I'm at, I have an Ontario driver's license and health card. I wanted to see a QR code be put on the health card and driver's license that have things like your blood type, some basic health information, some advanced care planning. You could even have directives on there. People thought it was way over the top and out of line because it was going to go past that line where you're revealing public health or personal health information. But yet, lo and behold, here we are today. I can only speak for Canada with QR codes on our phone with our COVID vaccination records to approve our immunity or our immunization. But the interesting thing about dialing in the health card or the driver's license is at the age of 16 is when you have your photo taken for it. At the age of 16, if you're privileged enough to be able to obtain a driver's license. If you're old enough and responsible enough to get behind the wheel of a car, why shouldn't you be responsible enough to articulate in whatever way, shape, or form what your future healthcare needs or desires are, or what's important to you? So I definitely believe that there has to be a solution to engage people younger, but also just general public. They don't understand a palliative approach to care until they age into that vernacular. They don't understand the vocabulary around what a palliative approach is until they're experiencing it or have gone through an experience where they've seen it. And then, I wish I had this earlier. Thanks.
Thanks. We have to wrap up now. You can see we need to talk about this a whole lot more. So please stay on, participants who've stayed with us so far. And Liliana is going to take us out.
Well, thanks everyone for being here, and special thanks to the panelists for their presentations, research, thoughts, and experiences. I think we all learned quite a lot. This is a great topic that we need to explore more and certainly gain more expertise. Also, many thanks to Catherine for her role as the moderator for today's session. We will upload the presentations, those who are willing to share, the panelists who are willing to share, and then we will also share resources that they are willing to share with us, websites and documents that you may find useful, plus the recording of this webinar on the IAHPC website under the advocacy section. So, in a couple of days, it should be all up there. After closing this webinar, a new window will open and your screen will be asking you to complete a brief satisfaction survey. Please take a few minutes to complete it. It takes maybe 2 minutes at the most. We do take your answers very seriously and into consideration for future webinars. Thanks again for joining us, and have a good rest of the day, afternoon, or evening, wherever you are. And thanks again.